Bismillahirrahmanirrahim. Starting in the name of Allah, the most beneficent and the most merciful, I welcome you all to G1, that is Global Village Oncology Network Metacampus session. And today we will be discussing approach to acute myeloid leukemia, game of basic and specialized knowledge under G1's Heme Oncology POD. Today we have as our presenters Dr. Kanta Devi, who is consultant clinical hematologist at Khan Hospital, Hyderabad. Along with Dr. Kanta Devi, our other speakers include Dr. Qadir Ahmed Baloch, staff pathologist at AKU Stat Lab, Quetta; Dr. Uruj Haider Hashmi, consultant clinical hematologist, Tabba Heart Institute, Karachi; Dr. Farooq Ziatareen, consultant clinical hematologist, BUCH and Multan Institute of Kidney Diseases. Over to you, Dr. Kanta. Best of luck.
Thank you so much, Mariam, for such a nice introduction for all of us. And so, begin with the presentation. I am very much excited and also feel so much honored that I am starting the first ever session of Heme Oncology at Global Village Oncology Network. So, I am really thankful for the team who given us that much opportunity that we are here to present about acute myeloid leukemia, the game of basic and specialized knowledge. So, throughout our presentation, all the speakers wouldn't have any conflict of interest. So, in today's presentation, we will cover introduction, clinical presentation, diagnostic approaches, journal management approach, and management in resource limited setting. From the topic will be covered by me and by my all speakers that has already been introduced by Mariam. So, beginning with presentation, I will briefly discuss about the basics or the basic introduction about acute myeloid leukemia. So, as a word itself said that acute leukemia, the leukemia that has acute presentation, and so the word itself said that the patient will present with the aggressive presentation and would definitely need immediate basic diagnostic and management approaches. So, acute myeloid leukemia, it's an aggressive blood cell cancer that arises from clonal expansion of malignant hematopoietic precursor cells in the bone marrow. So, among all the acute leukemias, the adult would cover the majority of AML. Around 90% of the cases with acute leukemia in adult are AML. So, what is the pathogenesis behind AML? So, it's a consequence of malignant transformation of myeloid precursor cells. And the transformation results in one or more clones of abnormal cells that can proliferate but are blocked in their ability to differentiate into mature blood cells, so that they cannot undergo programmed cell death. So, how it occurs, why these malignant cells could proliferate? It's all because of the certain specific chromosomal abnormalities that can be identified in more than half of the cases of AML. This could be because of certain recurrent translocations, rearrangement in chromosomes, or either because of certain genetic mutations that leads to these changes that would lead to the abnormal proliferation and leads to acute leukemia. So this is the picture that summarize all the pathogenesis behind the acute leukemia. So normally what happened that the primitive hematopoietic stem cells, they have to convert to the definitive hematopoietic stem cells, and then they can be differentiated to the different series like lymphoid, myeloid, megakaryocytes, and erythroid precursor cells. So to cover this journey that a primitive to the definitive hematopoietic stem cells, they need a certain genetic support. So whenever there is a defect in these genes, this causes the abnormal proliferation of these immature hematopoietic stem cells, and this immature proliferation obviously inhibit the normal hematopoiesis and leads to the complications that are related to the acute leukemia. So, what are the presentations that are common because of these abnormal proliferation of the blast cells? So, the signs and symptoms because of the inhibition of the normal proliferation lead to anemia, and the complications or the presentations be due to anemia like fatigue, pallorness, or the patient could present with the headache or the focal neurological complications that could be because of the proliferation of the blast cells to the brain or because of the thrombocytopenia related CNS hemorrhages. Physically, patient could be pale, patient could present with bleeding, bruising, hepatosplenomegaly, or other soft tissue mass due to myeloid sarcoma. Other presentations that are because of these leukemic blasts, they can also proliferate towards a tissue like skin, that is called as leukemia cutis, and to other organs or the lymphoid tissues, that is called as myeloid sarcoma. They can also these all are the different presentations of the leukemia. Further, because of the abnormal hematopoiesis or due to the inhibition of the normal hematopoiesis, thrombocytopenia or the coagulation disorders are really very common to AML. And other complications that are related to the AML is not because of the disease, but it could be because of the medications or the chemotherapy that is given to the patient. These can also lead to the complication that are similar to the acute presentation. So, some patients present with these general presentation that I have discussed early, but the majority of the patient with acute myeloid leukemia, they can present an emergent conditions, among which the most common is the pancytopenia and the pancytopenia related sepsis, pancytopenia related acute bleeding. Particular complications that are associated with a certain categories of AML is like DIC. DIC is the most common presentation of acute promyelocytic leukemia, and it is a medical emergency. If it could not be treated on timely basis, it is a lethal and causes a mortality in majority of the cases. So, the patient who is presented with bleeding, bruises, thrombocytopenia, along with leukemic blast in the peripheral smear, one should always think for APL, acute promyelocytic leukemia. Other complications that are the acute emergent conditions are the metabolic abnormalities, among which the most common is tumor lysis syndrome, that is again common in acute myeloid leukemia. So, what could be the metabolic complications that would give us an alarming sign is hyperkalemia, hyperphosphatemia, hyperuricemia, that could lead to renal insufficiency. Other is the CNS involvement along with the vision issues. This again warn us about the acute leukemic presentations. Hyperleukocytosis, leukostasis, it's an other emergent condition that could lead to the respiratory or neurological compromise. Again, warn us to a urgent treatment and urgent management of these conditions. So after these presentations, the main thing is to how to approach these cases, these emergent conditions, how one can approach to diagnosis, and what is the basic indication, or what is the basic significant of each and every diagnostic test that should be done in acute myeloid leukemia. That would be discussed in detail by Dr. Kadir Baloch, who is a consultant hematologist. Over to you, Dr. Kadir, about the diagnostic workup of AML.
Audible? Am I audible, Dr. Kanta?
Yes, yes, you are.
So I don't have the controls. Can you please keep on changing the slides? Yeah, thank you
Yes.
so much. My name is Dr. Kadir Baloch. I'm a consultant pathologist at Aga Khan State Lab, Quetta. As Dr. Kanta introduced or discussed the clinical presentations of acute myeloid leukemia, I've been tasked to discuss the diagnostic approach. So, first of all, AML is classified by WHO into two major categories: acute myeloid leukemias with defining genetic abnormalities, which include different genetic abnormalities causing the disease, and the other category is AML defined by differentiations. Basically, this one is the oldest of the classification, which was previously called as FAB classification. Can you move on, please? So, how will we approach a patient suspected with acute myeloid leukemia with any hematological disorder? First test to be done is complete blood count. Complete blood count gives us an idea of the hemoglobin level, total leukocyte count, and the platelet, and other parameters. And the next thing is to look the peripheral smear. The peripheral smear is, we take a drop of the blood, spread it on a slide, stain it, and review it under microscope. So mostly acute leukemias, they present with a normostic and normochromic anemia, thrombocytopenia. The TLC count may be low, or normal, or high. So the on the peripheral smear, blast cells are usually present, noted, and the morphological evaluation usually shows that these are medium to large in size, having moderate granular cytoplasm, prominent nucleoli, and our rods are usually seen. And in case of AML M3 or acute promyelocytic leukemia, These are abnormal promyelocytes having abundant cytoplasm with multiple auroras, which are called as faggot cells. So, as per WHO, we need at least 200 cells for morphological evaluation for the diagnosis of AML. Next, please. So, first, if there are blasts on the peripheral smear, we need bone marrow aspirate and defined for the confirmation of the leukemia, whether it's a myeloid or a lymphoid. So bone marrow aspirate basically is required for the morphological assessment as well as immunophenotyping and also for the genetic evaluation. The morphological evaluation, at least we have to count 500 cells and also look for any dysplasia and the other lineages like myeloid or erythroid or megakaryocytes. And in resource constraint settings, we can also perform cytochemical scans on the bone marrow spiral slides like Sudan Blake, MPOPS, and NAC. Next, please. So, bone refine basically is the tissue section which is taken from the bone marrow during the process, which is used for the immunophenotyping and the evidence of pre-existent or concurrent hematological diseases like is there fibrosis or are there mast cells or are there collection of plasmacytic cells. So how we label that whether it's lymphoid or myeloid, basically that's done by flow cytometry, immunophenotyping by flow cytometry, which we need at least 20% of the blasts, and the common panels which we use are the markers of immaturity like TDT, CD34, CD117, HLA-DR. For the myeloid, mostly the markers are 13, CD13, 33, MPO, 14, 11B, 235, 41, 42, and 61. The flow cytometric is diagnostic as well as it is used for the MRD evaluation after the treatment. Next, please. So after we have confirmed the phenotyping of the blast, next thing is we need to know the cytogenetic as well as molecular markers. Basically, these have diagnostic as well as prognostic significance. So bone marrow sample is required for cytogenetics, and other methods, molecular methods like FISH or PCR are required for the diagnostic. Further subclassification of AML, as we previously discussed, and the prognostic workup of AML, as some of the mutations or some of the abnormalities have prognostic workup. So WHO classifies AML into two major categories, as we discussed earlier. So, with cytogenetic workup, we identify categories like with translocation A21, 15, 17, or inversion 16. And molecular testing like PCR is diagnostic and also is used for MRD in conditions like acute promyelocytic leukemia and other fusion proteins. And the next, which is mostly available and good settings, is NGS. Basically in NGS we look for a specific a panel of genes which are mostly abnormal in acute myeloid leukemia, like RUNX1, RUNX1T1, CB, core binding factor beta, MYH11, PML, and the others. They have diagnostic as well as therapeutic and prognostic significance. So this is a summary of the presentation. Like whenever we suspect a case with acute leukemias, first we go through a morphological evaluation that will gives us an idea whether it's a lymphoid blast or a myeloid blast. Once we suspect there's a myeloid blast, then we go for the immunophenotyping that's further confirms that lineage of the blast, and the cytogenetic workup, which is for further subcategorizing, and cytogenetics for the subcategorizing, and the prognostic, or like as I previously discussed, myelodysplasia related changes. And the last one is molecular. Basically we have to look for the molecular abnormalities because they have therapeutic as well as prognostic significance, and we with specific abnormalities we have some therapeutic drugs which we can use for the patients.
Thank
Thank
you
you.
so much, Dr. Kadir, for such a brief discussion about diagnostic approaches. Now, talking about general management approach for AML, obviously the management approach for AML basically needs the diagnostic test that would help us in risk stratification, that would help us in decision making for management options at different stages of treatment. So, for discussion about general management approaches, I would invite Dr. Aruj Haidar Hashmi. She is consultant clinical hematologist. Over to Dr. Aruj.
Thank you so much, Kanta. Assalamu alaikum. I'm
Walaikum.
Dr. Arujadar Hashmi, and I am consultant clinical hematologist at Taba Heart Institute. Today, I'm going to talk about the general approach to management of patients with AML. I will not go into the very details of the chemotherapy. I will try to keep it very precise and very brief. Now, when talking about the general approach of the patients, first of all, we want to know that what is the risk stratification of these patients and whether these patients are fit enough to go for the intensive chemotherapy or not. So, the fit patients who are less than 60 to 65 years of age, they receive intensive therapy. And this treatment includes the induction therapy followed by the post-remission therapy that is called consolidation. Now, in the non-low risk patients, these are evaluated for the stem cell transplantation in the first remission. Next. In the less fitter patients like 70 to 75 years or older, or the younger patients with the significant or multiple comorbidities, they receive low intensity chemotherapy. The selected less fit patients with the very highly proliferative disease, however, may be considered for the intensive chemotherapy. Next. Now, this is the risk stratification as I was talking that when we start with the management plan of the patients, we have to decide whether they fall into the favorable risk category, intermediate, or poor. As you can see in this graph, there are certain like cytogenetic and molecular abnormalities on the basis of which we divide them into different categories. As far as favorable is considered, you can see that translocation 821 in version 6 and then mutated NPM1 without FLT3 ITD. These are considered in the favorable group. In the intermediate group, all those categories which do not fall in the favorable or the poor risk categories are then labeled as intermediate risk categories. And along with that, the mutated NPM1 with FLT3 ITD and wild type NPM1 with FLT3 ITD, they are also considered in the intermediate risk category. As far as poorest category is concerned, translocation 6-9, translocation 922, and then monosomy like monosomy 5, monosomy 7, complex karyotypes, and the mutations that include TP53, ASXL1, and further, as you can see in this chart, these are all considered in the adverse risk group. Next. Now, when we are talking about the treatment plan of these patients, those patients who are intensive induction eligible patients, mostly these are younger patients, and these are then further divided into favorable risk group. The favorable risk AML, the preferred treatment regime we include commonly using these treatment is the standard treatment, which is called 7+3, which include daunorubicin and cytarabine. We also can include gemtuzumab in the CD33 positive patients. There are other recommended treatment, however, the preferred treatment remains the same. In the patients with the AML with FLT3 ITD or TKD mutation, we can add, along with the standard therapy, midostaurin in these patients. In the intermediate risk category, again, the preferred treatment, standard treatment remains the same. However, we can offer other regimes that may include FLAG-IDA or FLAG-IDA plus minus venetoclax. Next. Then there come the poor risk AML with and without TP53 mutations. Uh, Again, in these patients also the intensive therapy remains the same. That includes the standard therapy, that is 7+3. Another treatment you can see in these may include high dose anthracyclines, FLAG-IDA, and then there are hypomethylating drugs. But the preferred regime usually which is followed is the standard regime. And then there are therapy-related AML or antecedent MDS or CMML patients or cytogenetic changes, which is mostly consistent with the MDS. In these patients, we can also consider adding the dual drug liposomal cytarabine and daunorubicin, and then the standard therapy, decitabine as a cytidine, and so on. Next. Now, the point is that when we initially give the induction chemotherapy, how to follow these patients and whether the induction is needed or not needed, this is basically decided on the follow-up bone marrow aspirate, which is usually done at 14 to 21 days after the start of therapy. Now, if the patient at this stage, when the bone marrow shows significant residual disease without a hypocellular bone marrow, we straight away go to the reinduction. In the patient with a significant site reduction that is less than 20% cellularity, but more than 5% blast cells or vice versa, the bone marrow biopsy, in the ambiguous cases, the bone marrow biopsy can be repeated after several days. And again, we go for the reinduction in these patients. And this reinduction may include the same regime that was standard 7+3 or other regimes that may include high dose anthracyclines and different therapies as well. However, in these patients who have hypoplasia at this stage, when we do the initial bone marrow, we basically await for the recovery. Now, previous slide, please. Now, once we have given the reinduction, when we have to follow and how we have to follow is that we have to do the bone marrow biopsy again to document the remission status. But the stage at which the ANC is more than 1 and platelet is more than 100, we go for the bone marrow biopsy. Now the question is that what if the ANC and platelet has not achieved after 35 days post-treatment and there's no evidence of such hematological recovery, we go for marrow biopsy anyhow. But if there is some recovery but not to the level of ANC more than 1 and platelet more than 100, we wait up to another 1 week. But important point here is that if at day 22 post treatment the patient remains the patient does not achieve the hematological recovery, we have to go for the bone marrow biopsy. Now, in this biopsy, as per the response or the remission status, we further decide the treatment whether it should be the consolidation therapy or whether we should move to the mass sibling or alternative donor bone marrow transplant. Next. Now, the consolidation therapy. Now, as we talked earlier, that the treatment basically is based on the risk stratification. Those patients who are favorable risk in these, the consolidation may include the chemotherapy. However, the patients with the poor risk AML, if they are eligible for the transplant, we prefer to go for the match sibling or alternative donor transplant. However, if the patient is not eligible, we can consider other chemotherapy regimen. Next. Now, this is the basically for those patients who are not a candidate for intensive induction therapy. Now, in these patients, what we do is that we see whether the patient does have any actionable mutation or not. In those patients who does not, the preferred treatment, because we cannot give the intensive induction therapy, we can move on to azacitidine and decitabine along with the addition of venetoclax. This is the preferred regime. In those who have the mutation, actionable mutation like IDH1, IDH2, the preferred regime may include the similar as the previous one, but we can also consider adding the targeted therapy towards these mutation. That is, ivosidenib or enasidenib can also be added. And when the patients have FLT3 mutations, sorafenib can be added to their regime or the standard treatment which we are offering them. Next. Well, and now after how do we follow up and about the reinduction therapy in these patients? Again, the bone marrow has to be repeated to document remission. If there is a response, we can consider the continue lower intensity chemotherapy regimen, or we can consider allogenic transplant depending on the risk stratification before which has been done previously. And if the patient does not show any response or has progression of the disease, then we can also opt for the best supportive care in these patients. Next. Now again, in the patients with the age, the patients who are not the candidate for intensive induction chemotherapy, when we talk about the consolidation therapy in these patients, it remains again the standard dose cytarabine or intermediate dose. We were discussing previously of the high dose cytarabine. In these patients, we can consider giving them intermediate dosages or lower doses chemotherapy. Rest of the things remain same in all the risk groups that we can consider intermediate doses as well as allogenic transplantation. Next. Now, this is also important that when and how to evaluate patient for CNS leukemia. Now, it's obvious if at the diagnosis patient does have neurological symptoms, we go for CT or MRI to rule out any bleeding or any mass effect or mass lesion. If the CT or MRI is negative for any mass lesion, we go for lumbar puncture. In the negative lumbar puncture, we observe and repeat lumbar puncture if the symptoms persist. But if it is positive, by morphology or by immunophenotyping, we consider giving the intrathecal chemotherapy twice weekly initially until the lumbar puncture becomes clear, or and then followed by weekly for 4 to 6 weeks. Previous, please. Now, those patients. Now, this is very clear for the patients who are having neurological symptoms at the diagnosis. But for the patients who don't have neurological symptoms, we consider first remission screening in certain groups of the patients, which may include the patients with monocytic differentiation or MPAL or with WBC count of more than 40,000 at diagnosis, or patient having extramedullary diseases, or patient having FLT3 mutation or high risk APL. In these patients, we do go for screening lumbar puncture at first remission. Again, if the lumbar puncture is negative, we observe and repeat if needed. And if it comes out positive, the course remains the same, that is intrathecal chemotherapy twice weekly initially. Next. Now, when we talk about the treatment of acute leukemias, it is very important that the supportive care should be taken care of because it can improve the prognosis of these patients, it can reduce the morbidity and mortality in these patients. So it is very important. Uh, One very important thing is the blood products because these patients need very frequent transfusions, especially in the induction period. All the blood products that we offer to these patients ideally should be irradiated to prevent the transfusion-related graft versus host disease. And as far as the transfusion thresholds are considered, hemoglobin should be kept more than or equal to 7 to 8 grams per deciliter, or in certain patients who have significant cardiovascular or respiratory compromise, we have to keep this threshold even higher. Next. The platelets should be transfused at the count lower than 10 to 20,000 or at any count when patient is bleeding. Patients with the pulmonary or GI hemorrhage should receive platelet transfusion to maintain a count greater than 50,000, and for CNS hemorrhage, this count should be more than 100,000. Next. Infection treatment and prophylaxis, again, very important thing in these patients. So all the febrile patients during the induction period or during the intensive chemotherapy period should receive intravenous antibiotics, and these antibiotics should include broad spectrum coverage. The patients who have persistent fever despite giving the antibiotics, we need to do the CT scan of chest, abdomen, pelvis, and sinuses as well, along with the fungal markers. Next. The prophylactic antibiotics usually used in a non-febrile patient undergoing intensive chemotherapy. Antifungal prophylaxis in this group of patients is also strongly recommended by different groups. And the following combination may include quinolones, azoles, and antivirals. Next. Growth factors. Growth factors also, again, because we have severe neutropenia during this phase, we may need growth factors as a part of supportive care for the post-remission therapy. But the important thing is that whenever we have to go for bone marrow to document remission, it should be taken into account that patient should be off these growth factors for at least 7 days before we go for a bone marrow biopsy. Next, tumor lysis prophylaxis. Now, again, in the patients who present with very high cell count, when we go for the induction chemotherapy, there's very high risk of tumor lysis prophylaxis, and as previously told by Dr. Kanta, it is an emergency. So we have to give the proper hydration along with diuresis during this phase, and the treatment that may include allopurinol, respiricase. Usually allopurinol is given, but in the patients who are considered having a rapidly increasing blast counts or high uric acid or evidence of impaired renal function, they're started with the respiricase. Now, how do we monitor the patient during this intensive therapy? During the induction, we need a very frequent testing of these patients, CBC, which should be done ideally daily and every other day after recovery of WBC count more than 500 until either normal differential or persistent leukemia is documented. Platelets daily while in the hospital until platelet transfusion independent. Chemistry profile that include electrolytes, liver functions, and renal function tests, uric acid and phosphorus at least daily during the active treatment until the risk of tumor lysis is passed. Liver function test once to twice weekly. Similarly, coagulation panel also once to twice weekly. Bone marrow aspirate, as we discussed previously, 14 to 21 days after the start of therapy, document hypoplasia. If hypoplasia is not documented or indeterminate, repeat biopsy in 7 to 14 days to clarify persistence of leukemia. And if the hypoplasia, then a repeat biopsy at the time of hematological recovery to document remission. And if initially cytogenetics were abnormal, then this repeat biopsy should include the cytogenetic as well. MRD, now MRD, as already discussed by Dr. Kadir, I will be also touching very precisely this topic. MRD, the role of MRD in prognosis and treatment is evolving in acute leukemia, especially now as we are talking with AML. It refers to the presence of leukemic cells below the threshold of detection by conventional morphological method. It is a component of disease evaluation over the course of sequential therapy, and patients whose disease achieve a complete remission by morphological assessment alone can still harbor a large number of leukemic cells in the bone marrow. Next. Now, the most frequently employed methods for MRD include real-time quantitative PCR and multicolor flow cytometry. The threshold to define the positivity and negativity for MRD depends on the technique and the subgroups of AML. Now, it is important that we should consider that MRD positivity is not a proof of relapse. However, a persistently positive MRD result after induction, which depends on the technique used, is associated with increased risk of a relapse. For patients with the favorable risk disease, if MRD is persistently positive after induction or consolidation, consider clinical trial or alternative therapies. They may include allogeneic transplant. And after completion of therapy, the molecular relapses can predict hematological relapses within a 3 to 6 months time frame. So how do we were talking about the response, about the complete remission all this time. How do we assess the response criteria? What are the response criteria definitions for acute myeloid leukemia? So the morphological leukemia-free state is considered when the bone marrow contains less than 5% of the blast cells. It is important that at least 200 cells must be enumerated. No blast with overodds or a persistence of extramedullary disease. Now, this is also important that if we do not have spicules in the aspirate sample, ideally the bone marrow biopsy should be done. Next. Morphological complete remission is when the patient is transfusion independent and ANC of more than 1,000 and platelet of more than 100,000 with blast cells of less than 5%. Complete remission without MRD if studied pre-treatment, complete remission with negativity for a genetic marker by PCR or by multicolor cytometry. Molecular complete response when the molecular studies are negative. So the complete response with a partial hematological recovery that is less than 5% blast on marrow, no evidence of disease, partial recovery of peripheral counts that is platelet of more than 50,000, ANC of more than zero point 0.5. Complete response within complete hematological recovery is that all complete response criteria and transfusion independence, but with the persistence of neutropenia that is less than 1 or platelets less than 100. Partial remission is that the decrease of at least 50% in the percentage of blast to 5 to 25% in the bone marrow, normalization of the platelet of the blood counts. Relapse following complete response is the reappearance of the leukemic blast in the peripheral blood or the finding of more than 5% blast in the bone marrow, which is not attributable to another cause, for example, bone marrow regeneration after consolidation or extramedullary relapse. Lack of response to induction is inability to attain complete response or complete response following exposure to at least 2 courses of intensive induction therapy. Thank you so much.
Thank you so much, Dr. Aruj. To make it so precise, obviously, the AML recommendations regarding management is a huge topic, and you try to cover each and every step, starting from the management to the approach, how to follow, and what to do in relapse settings. So, it was about the recommended management. So, the main challenge that is faced by the hematologist is in the resource limited settings. So, Dr. Farouk, who is a consultant clinical hematologist, will cover how to approach in resource limited settings. Over to you, Dr. Aruj or Dr. Farouk Ziatareen.
Assalamualaikum, Dr. Kanta. Thank you very much for offering me this opportunity to present at this forum, which is the great effort by Dr. Hamad. I should appreciate both of you giving me the opportunity to present through this forum. And coming toward the topic, AML management in resource limited settings. I have chosen this topic because this is the least discussed topic, however, the most commonly faced in our small cities. Probably the most faced scenarios, which I have also experienced here when I came back to Multan after completing my residency and started my practice. Then I experienced multiple scenarios which urged me to present on this topic today. So coming toward the exact topics and our line. The challenges, first of the challenges were diagnostic. Initially, whenever the patient came to the general hospitals or initially at the basic health units or the C headquarters or the tertiary hospital, the encounters for those patients were in the emergencies or in the OPDs with the junior officers. These junior officers are not trained much or they don't have an exposure to these patients and they are unable to recognize that these patients are presenting with the constitutive symptoms of weight loss, night sweats, fever. So initially, they just gave them treatment of the infections and didn't bother about the complications of febrile neutropenia, tumor syndrome, and blah blah. So that's why that resulted in delays of the patient's diagnosis as well as their complications were enhanced. Secondly, those patients, when they presented with these small hospitals, smaller, the compromised tertiary care hospitals, like our government hospitals in smaller cities, then they were ordered the investigations which were not relevant, such as they were not ordered peripheral blood film along with the test of CBC, so which is very important in detecting the blast cells and making the exact diagnosis regarding acute myeloid leukemia or any other leukemias or any other hematological malignancies. So that's why that resulted in delayed diagnosis or false diagnosis. Similarly, that ultimately result in the lack of timely or proper reference to the clinical hematologist that cause the burden or the patient of disease frustration, disease complications, as well as the economical burden. And when they ultimately reach the concerned consultant, they don't have any economical or financial budgets to bear the cost of the chemotherapy treatments which are available. So, previous slide, Dr. Kanta. I'm just on the diagnostic. Yeah. So, along with these, there are local myths and treatments of heme and also the coax, which resulted in the increased complications of those patients. And it was a hurdle in those patients coming toward the exact consultant for the treatment. So also these compromised tertiary hospitals don't have any specialized pathology labs, and the compromised labs do have there in their laboratories, but they don't have any specialized skilled technologists to perform bone marrow biopsies or to take the proper sampling of that for the purpose of diagnosis of this acute leukemia. So next slide. So the diagnostically, there the patient face the huge challenge to start their treatment because to start any therapeutic treatment option, you should be having exact diagnosis and exact line of management. So if the treatment is delayed, if the complications are a lot, and if they're not reaching the exact consultant of consultant clinical hematologist, obviously they are going to complicate and they're not going to have any appropriate treatment available. So, in the challenges which are therapeutic in managing these patients, the obstacle is there's lack of the clinical hematologist or the concerned consultants to treat acute myeloid leukemia in our smaller cities such as in Multan. Along with that, there's a lot of malpractice being performed by our colleagues, which are physicians, which are any kind of specialties. They are not referring the patient to the proper consultants as well as treating themselves without knowing having the knowledge of the disease and how to treat it. Similarly, there are the treatment options available in our country is very expensive and it comes in back from the imported market, which causes high economical burden to bear the cost of these treatment options, including chemotherapeutic drugs and targeted therapies, which results in the patients not getting treatment properly because of lack of their financial cost. Similarly, the hospitals, the compromised tertiary hospitals in the government setups who are offering the oncology services, however, they are not up to date or not having the proper chemotherapeutic setups, chemotherapeutic pharmacies. Similarly, there are not radiology setups in which can perform CT scans, biopsies, CT guided biopsies, MRI scans, and staging workup. So these compromised options, these are leading to the patients' complications, and they are not having that getting true treatments. So next, when we start treatment to the patients, we obviously have we should have the supportive care and trained oncological nursing care, which is severely lacking in our country. The nurses are not properly trained how to administer chemotherapeutics and how to counsel the patients and how to manage those patients and offering the multiple options which can result in remedy of their miseries. So the next slide. So treatment options are very limited in the resource constrained settings or tertiary hospitals. Multiple hospitals are usually following the compromised regimes and conventional therapies, and also along with that, they are giving patients the suboptimal doses of those regimens in order to reduce the toxicities because they don't have modern ICUs to cater the patient, which are resulting in increased relapse rate and refractory disease. So that's why this is a big challenge to treating these patients, especially of acute myeloid leukemia, which usually any other doctor do not treat and do not get responsibility to treatment for there. These options include our TREM, which is a conventional therapy consists of prednisolone, etoposide, and 6-mercaptopurine. The complete remission rate and 1 year survival rate were 46% and 45% respectively with this kind of therapy, which is a kind of conventional and less toxic chemotherapeutic regime, which can be given in the smaller cities with the hope of treating this AML disease. Second was the conventional azacitidine or descitabine along with or without venetoclax, or simply the low dose Araci, that is low dose cytarabine, which is 100 milligrams a day for those patients who are on palliative and supportive care or do not have the option of getting the proper or classical treatment, modern treatment such as the targeted therapies, IDH1 inhibitors, IDH2 inhibitors, or the FLT3 inhibitor as described by Dr. Uruj. So the patients do not have any multiple treatment options which are available in the advanced countries such as Europe and US. So following mainly the conventional chemotherapy of 3+7, that is daunorubicin and cytarabine, or along with that they are getting the suboptimal doses in our smaller cities, which is causing them more into complications as well as getting less treatment for and not a disease remission. So thank you. Thank you, Rakant.
Thank you so much, Dr. Farooq, for sharing experience that you are doing with your patients in limited resource setting. So I guess it would be beneficial for all those who are working in limited resources center like me. So I would try to try it for my patients also. And thank you so much for my speakers, Dr. Kadir Ahmed, Dr. Aruj Hashmi, and Dr. Farooq Zia. And I'm also thankful for Dr. Maryam Hina for all her support, help, and to share the platform for us. And thankful to Dr. Hamad who have initiated this global network and have also given the chance to Heme Oncology. So we would continue to present these kind of sessions, and we would continue this series of AML. So today we have just tried to cover the basic approaches that are recommended and what we are doing and what we are doing in resource limited settings. And in next session, inshallah, we will try to cover the case based discussions in which we will continue the same approach starting from the presentation to the diagnosis and then to recommend it to the resource limited setting management. Thank you so much. So over to Mariam Hina, and she can conclude the presentation by saying final words regarding Meta Campus. Thank you.
Thank you so much, Dr. Kanta. Thank you, every speaker. This was a wonderful talk, and each one of you has highlighted all the pertinent topics regarding the management of AML. Thank you, everyone. Let's conclude our session. These are the provided links where you can contact us, and feel free to contact us. Let's hope that we continue to do all such sessions in the future as well. Allah Hafiz.